Great. Hello, everyone. Yeah, thank you for the opportunity to come and share about my experience and perspective on emergency medicine. I enjoy in kind of engaging with students of various levels, and one of the reasons I have enjoyed being at Stanford is the opportunity to work with, again, undergraduates, medical students, post grads, and any opportunity to share what I think is an amazing field. I look forward to that. So I'm hoping that this can be a very interactive session. And what I wanted to do is primarily just describe my perspective on what emergency medicine is for those that may not fully appreciate all the nuances among all the different medical specialties. Um, I have a few slides just to prompt some discussion, but certainly feel free to put questions in the chat or just ask questions. And so as was described, I'm emergency physician by training. I also have a role at the School of Medicine administratively, and so in a hospital, in an academic hospital that's affiliated with the university. Part of our responsibilities is research, education, and clinical. And those are kind of the three missions of any academic hospital. And so I work with a emergency medicine residents that we have about 60 residents in our program. Also work with medical students that rotate through the emergency department. Of course, I see patients in our emergency department. And then, I also try to publish on various aspects of operations. My personal research interest is around how to make care better in the emergency department, how to design systems so that when patients show up in the hospital, they can get the care that they want more efficiently, high quality, more higher safety, all those kind of things. So those are kind of the areas that I'm involved with. And so with that, I'm just going to share my screen. And again, this is a very simplistic view of emergency medicine that I thought, again, just to initiate conversation. And so in general, like, what do you guys think about when you think emergency medicine? I mean, obviously there's a lot of people in the audience, but yeah, anybody want to just take a crack when you think about, when you hear the term emergency medicine? I see in the chat box, trauma, fast pace, first responders, fast react. Yeah, excellent. Paramedics, stressful, be on call all day. All right, great. Yeah, no, absolutely. These are the kind of things that are definitely a part of emergency medicine. And in some ways, I would say that's also some of the reasons I think that attracts people to the field. And I will say that when you think about, I'm sorry. Okay, I will say that my first impression of emergency medicine was actually from TV. Growing up, high school, college, started to see some shows that became popular. ER at the time was pretty popular, and then and that kind of frames your perspective on what medicine's all about. And you'll even now to this day, I sometimes will find it funny when I look at what shows are on TV or in the movies and say, okay, what's more realistic and what's less accurate. And again, you'll see that there's a variety of shows that often will portray the drama that comes with emergency medicine. I can tell you, it's often not that dramatic, but at the same time, that's what makes it a good TV show or a good movie or what have you. But emergency medicine comprises a lot of different elements. The one that many of you have touched on is the stress, the trauma, and one of that is CPR, right? Somebody collapses, they're about to die, and you have to resuscitate them. And that is definitely one of the distinguishing features of emergency medicine, is that you're dealing with the most critical aspects in the healthcare field. But it's just interesting in terms of how it's portrayed versus what I want to describe as some of the realities that in movies. Somebody actually did a study where they looked at all these different shows and movies and calculated how often people survive CPR in the movies, and it's somewhere close to like 17-18%. I mean, the reality is that the people who get to that point in the ER, it's actually closer, probably less than 5%, and maybe even less than 3%. But again, I just highlight that that what we often see, the drama of somebody picking up these pads, kind of rubbing it, and then shocking someone that then bounces off the gurney. There are obviously elements of that
In
that
this
are
video,
accurate.
we will go through some examples of the power rule.
And so, yeah. And so often another thing associated with emergency medicine is, right, this concept of someone who's about to die having a flatline or asystole. And again, these are all important aspects that help characterize, the idea that if someone's very terminal, what can you do for them, and what field will be responsible for this? It's also associated with heart attacks, right? Something very sudden, very severe that needs immediate attention. Trauma, a lot of you mentioned trauma, and absolutely, I would say that aside from trauma surgeons, emergency medicine is the only other field that uniquely places you at the moment when somebody has just undergone a very, very traumatic event. Of course, then on the other end, you could still have injuries that maybe aren't life-threatening, but at the same time, they still need to be addressed. If you cut your hand or finger and you need sutures, it's not something you're going to say, well, let me make an appointment with my primary care doctor for 2 weeks from now. You want to get it addressed, you want to get it taken care of. It hurts and it's bleeding, and so this is the other end. The other thing that I would say is often associated with emergency medicine is controlling someone's airway and breathing. And so one of the most important aspects of emergency medicine is that when someone is so sick, they get to a point where they are not able to breathe for themselves for whatever reason, whether it's from trauma, some medical reason. And so the ability to breathe for them through a procedure called intubation, where essentially you put a tube down to their trachea into their lungs, hook it up to a machine that then pumps oxygen, and then carbon dioxide gets removed. That is a very critical function. In order to do that, you have to paralyze the patient and sedate them. And so if you imagine sedating someone and paralyzing them so that their lungs aren't moving at all on their own, then it can be a little scary, because if you don't do that procedure correctly, or if you can't get that procedure done, then that patient has no ability to breathe on their own and they will die. But of course, you have to do this if you feel the risk is worth the benefit. Um, and now, if you can't do this procedure, and there are times that happens where somebody has massive facial trauma, so you can't even visualize or get into the oral airway, or if you, for whatever reason, fail because there's so much swelling. So sometimes people will have an allergic reaction, and their tongue and the back of the throat swell so much it becomes impossible to put that tube down. Then you have to do a surgical airway, where you make an incision at the windpipe and then put the tube that way. And so the reason I just in particular mention these two procedures is just because these are ones that are, I would say, uniquely emergency medicine. There are anesthesiologists whose job it is to sedate someone when they go to the operating room, and so they are obviously very expert at putting in the intubation. And then there are surgeons, ear, nose, throat surgeons, trauma surgeons that can also do a surgical airway. But I would say emergency medicine is the only field that is trained to do both of these, just because if in an emergent situation, you should be comfortable doing any procedure that allows you to stabilize a patient. Let me advance. The other unique thing about emergency medicine is the type of patients you see. And so on one end, you have a baby, a neonatal patient, a toddler. On the other end, you have the elderly, older patients. Then you also have female patients, male patients. You also have pregnant patients. Well, each of these types of patients, there is a specialty for them. You have neonatologists, you have pediatricians, you have OBGYN, and you have geriatricians. And then you also have internal medicine for adults. And so certainly there are specialists for each one of these. But emergency medicine is unique in the sense that you're trained to care for every single type of patient from 1 day old to 100 years old, whether they're pregnant or not. And that's something that, again, that feature tends to attract people into the field, whether you like that or you don't. That's one of the distinguishing hallmarks, is that you can and should be able to address concerns of all types. And so I will conclude by saying, at least for the presentation part, just by saying that medicine as a field is so much more complicated in 2021 than it was 10 years ago, 50 years ago. And so what's happened is that medicine has become much, much more specialized. If you have a skin condition, you might think, I'm going to go see a dermatologist. If you have a heart condition, you would think, let me go see a cardiologist. And even within cardiologists, you might say, well, I have a rhythm problem of my heart. And so you would see an electrophysiologist within cardiology. So it's getting very, very subspecialized. And so when I think about emergency medicine, I think about how you are the specialist when it comes to the most critical, acute aspect of someone's care. But having said that, you cannot know everything. It is not possible to be the expert in every single field. But what we do have is the breadth of the conditions, whether it's the young to the old, but you are not going to have the depth of, let's say, an ophthalmologist that only specialize in, let's say, the retina or the cornea for 30 years. And so that is one difference, is the breadth versus the depth. But within that breadth, you are focused truly on the acute aspect of care. And I'll give you a good example. In the emergency department, if we see someone with back pain, our training will say, when we think back pain, we're thinking what is the most serious thing and the most emergent thing that could be happening with back pain. So right off the bat, we're going to be thinking, could this person have a infection of their spinal canal? Could they have broken their back? Could there be a cancer in the back that's pushing on it, causing them to be paralyzed in the next day? And if we can quickly rule that out, then we can then start thinking about other things that are more common. Like maybe it's just that they lifted a heavy box and they tweaked their back and now they're a little sore. But our training says you have to think about the most emergent first. Now, contrast that with a primary care physician. If you went to see your primary care doctor and you told them you had back pain, their approach is a little different. Their approach isn't necessarily to think, oh my gosh, you could die or be paralyzed in the next several hours. Let me make sure you don't have a spinal cord injury. Their first thought is, what is the most likely and the most common? And if someone comes in with back pain, typically the most common is they strain their back. They try to lift something heavy. They were exercising. They might have just pulled a muscle, and they would address that first. And so that's just an example of kind of contrasting the emergency medicine perspective versus others. I will also just mention in terms of the training, because that's a question that comes up a lot. So certainly after you finish college, after you finish your undergraduate degree, you go to medical school. It's a typical 4-year medical school program. The residency after medical school is 3 or 4 years. Most programs are 3 years, though there are some that are 4 years. And the difference being that the 4-year program tends to promote academics. So people who tend to go to 4-year programs want that extra year to build additional research, educational experience so that when they finish, they can get a job in the academic field. So Stanford's residency program is 4 years, but the clinical training are all very, very similar. Once you finish your 3 or 4 year training in emergency medicine, you can then get board certified in emergency medicine. Then you can also do fellowships, which are specialties within emergency medicine. And so some of the common ones are toxicology, so which is very fascinating, right? So the ability to kind of understand how people are affected by almost any drug if you overdose, whether it's intentional or unintentional. Hyperbarics. We also have ultrasound. So one of the distinguishing features of emergency medicine is using bedside ultrasound as a tool for diagnosing. And again, there's many other fellowships. I'm happy to answer questions. People are curious. At Stanford, we have 12 different fellowships that you can do after doing your 4-year residency. And these fellowships are typically 1 to 2 years. So it's a fairly long road, but it gets more interesting, I would say, as you progress because you're doing, essentially what you want to do. So with that, I'm happy to kind of pause and And yeah, I'm gonna take questions or yeah. All right, and I'll try to monitor the chat as well. Let's see here. Oh, I like that reference to E Road. Um, so these are the specialties that tend to be, I think, associated with a better lifestyle and potentially happiness. I would say, emergency medicine, the way the job is structured, you don't work your typical 40 hours a week. Typical full time is 3 to 4 shifts a week. And sometimes they're 8 to 10 hour shifts. Again, there's a lot of variability, but I think the thing that draws a lot of people to emergency medicine is that because it's shift based, you go in, you might work really hard, but when you finish your shift, you typically are not then caring for the patient and beyond that, because you're caring for the patient during the time they're emergency department. And so some people really like that aspect. Let's keep going. Again, if people have questions, feel free to ask. Otherwise, I'll try to go through the chat box for questions. Next one is, how many years is a surgical residency? So general surgery is typically 5 years. And then if you do a subspecialty within surgery, then it might be another 1 to 2 years. Nowadays, they're actually combining a lot of surgical specialty, so that instead of doing general surgery and then plastic surgery fellowship, it's all combined. So it might be a 5 year combined plastic surgery residency, or ear, nose, and throat surgery, or vascular surgery. Yeah. Yep. And then it's 5 to 7 years because some programs, like Stanford, will ask that you take 2 additional years to do research. And so when you are looking at residency programs, at that point, you're going to want to consider, are you someone that has an interest in being in academic medicine, potentially doing some research, some teaching? If you do, you're going to want to go to a more academically oriented residency program. And in those programs, they often will ask you to stop out for 2 years, typically between your second and third year of residency, to do research and build that experience. How is MD MBA structured? Yeah, I mean, that's obviously another big topic. So I did my MBA during medical school. So I stopped out between my third and fourth year. And you'll find that, and I did this about, I want to say about, over 10 years ago. But there are a lot more MD MBA programs now than when I did it. I did it at UCLA, and when I did it, it was it was at the time, it was just starting to be formed, and so I actually had to apply for both programs separately. But now you're going to find there's a lot more integrated programs where you apply to med school and business school at the exact same time, and it's usually a 5 year program. So you do save 1 year because MBA is typically 2 years. Again, the reason I did it is because I had spent some time before medical school in management consulting, and I really kind of liked the business aspect, but I knew I wanted to practice, and I also like finance, and so I wanted to kind of incorporate all those things together. And so for me, it made sense to do that. And again, there are lots of different reasons you can do MD MBAs. Especially now that in healthcare, you're going to find a lot more physicians are taking leadership roles, running hospitals, taking on administrative roles. So I think having that MBA can be helpful. What is a typical day in your life? So I would say that, there's, to answer that, I will kind of split up between a community hospital practice and an academic hospital practice. So I've been at Stanford for 7 years now. Before I was at Stanford, I was practicing in a much more traditional community hospital setting. And so in that setting, which is more common, I would do about 15 shifts a month, and I would schedule those shifts however I schedule them. Sometimes they're nights, weekends. That's just the way emergency medicine works. I would show up, and when I come into the emergency department, I would take sign out from the previous doctor who's caring for patients, and then I would take on those patients and start seeing new patients. And then my shifts would be typically 8 hours. And then when I'm done, I would sign off my patients if I'm not completed to the next incoming physician. And um, and when I got home, I didn't have to necessarily worry that I'm still caring for any patients. After the first couple of years, I started taking on more of an administrative role. So I eventually became the chair of that department. And so in my administrative role, you start having to do more management activities. And so I was dealing with, process improvement, operations, staffing, hiring. Again, some of the things you think about if you were managing a business, so to speak. And in some ways, if you think of an emergency department as a business, administratively, you are functioning as, let's say, the chief operating officer or the CEO. And so over time, I took on much more administrative responsibilities in addition to seeing patients. Now, in the academic world, my typical day, I see patients 1 day a week. So I do 4 shifts a month instead of the 14 to 15 shifts a month. But the one shift a week, it's very standard. I work in a trauma center. I see patients similar to what I would be doing if I was in a community hospital. But the other 4 days a week is also administrative. I'm giving lectures to med students or to residents. I'm also working on operational projects to try to improve the patient flow. I meet with other doctors, other administrators, nursing at the hospital. I get to kind of launch different programs. Like I just worked on a telemedicine program where we launched a telemedicine so patients can be seen by audio visual as opposed to just having to physically come to the ER. I also study certain things. We try to study ways to improve patient care. And so I would say, my day to day is about 80% where I'm working on those type of projects, and then 20% I'm seeing patients. All right. A lot of people are between both emergency medicine and trauma acute care surgery. What made you choose emergency medicine rather than trauma acute care surgery? That's an excellent question. I would say that during my second and third year medical school, I actually was debating very strongly between general surgery and emergency medicine. I think the thing that tipped me over to emergency medicine, and the reason I like surgery is because I really like working with my hands. I like that feeling of there's a problem, you see it, you fix it. And that almost like instant gratification. And that actually is very similar to emergency medicine. Because typically, when you see a patient, your goal is to quickly evaluate them, diagnose, hopefully treat them, and then you move on to the next patient. Um, so the thing that I think made me choose emergency medicine is that, at least growing up, when you think about, if somebody's sick, they always say, "Oh, I know a friend who's a doctor. Why don't we call this person?" I always found it kind of dissatisfying where if you call the doctor to say, "Hey, I have a question. Can you help with this?" And they say, "Well, actually, I'm a dermatologist or I'm a eye doctor and I can't really help you. Why don't you call someone else?" I guess in my mind growing up, I always thought that a doctor knew everything. And obviously that's kind of naive. But I just assumed that, gosh, if you had a friend that's a doctor, you should be call ask him about a problem with a kid, or whether you're pregnant or you're old or your skin or heart or whatever. And I think so. What drew me is the fact that I feel like if anybody ever asks me any question, if you're out in the middle of nowhere, if you are on a plane and something happens, I feel like emergency medicine prepares you to essentially kind of be the doctor that can support, answer, and hopefully manage a lot of different scenarios. So it's rare for you to then say, "Gosh, I have no idea. I only deal with the skin." Not that there's anything wrong with that. It's just that that's just the nature of the field. And so even with acute surgery and trauma surgery, you're still focused on just that one aspect, which is the surgical aspect of care for someone who undergoes trauma. I wanted to be able to kind of, see something broader than that. And so at least for me, that's how I chose it. And I find that most people in emergency medicine, they're kind of people where they liked all the rotations. Like I loved my rotation in pediatrics and OB and surgery and ear, nose, throat, plastics. I liked all of it. And so emergency medicine kind of allows you to do all that. Um, do you know if emergency medicine PAs have residencies as well? Um, Traditionally, they do not. but there are PA residencies, and it's usually 1 year, some are 2 years. So Stanford actually had a residency program for PAs to do just emergency medicine. It's again, it's a small, it's a limited subset of all the residencies out there, but it does exist, and usually for people who want to stay in academic medicine, because otherwise you technically do not need a residency to work in a emergency department as a PA. What is a typical week structure for a medical resident? Yeah, so a resident will rotate through different fields in emergency medicine in the 4 years, and with each year you get more responsibilities. But one key difference for emergency medicine is that you spend obviously most of your time in the ED, in the emergency department. The weeks are usually about, I would say, 60 hours if you include the educational component. So you might physically be in the emergency department for, let's say, 50 hours, but you might have up to additional 10 more hours of lectures and things like that. It used to be that the limit was 80 hours, but they have since really tried to manage the hours to keep it, to have a better wellness and balance. All right. I guess I'll keep going on. How did you decide emergency medicine? I kind of mentioned that in terms of kind of what the scope and of emergency medicine. The other thing I didn't mention, I'll say, is that because I went and got my MBA, I knew that I kind of was interested in something entrepreneurial, actually, and something potentially that's not your classic medicine. So I actually spent, between business school, I actually worked for an investment bank. And then after residency, I worked for a telemedicine startup company. And so I knew that I kind of had different interests. And emergency medicine is nice because it allows you to support other interests. Because if you were a primary care physician, you are tied to a practice, Monday through Friday, Monday through Sunday, you're on call. Whereas emergency medicine, I can titrate the shifts. I can work more clinically if I wanted to, or less clinically if I wanted to. And there have been times where I have been much more involved in my startup company. And so I can then titrate that and vice versa. So it does provide that flexibility, which that in addition to, of course, you have to enjoy the field. I decided on emergency medicine, third year medical school. Everybody who says that they start med school and they know exactly what they want, that's great if you are that person, but I found that it is very rare that somebody who said, I wanted to be a pediatrician on day one, then at the end of the fourth year, when they're going to residency, I find that majority of people will often have switched, because it's really hard to know what you want to do for the next, 20, 30 years until you actually are rotating in it. And then what ends up happening is people will find out that they like it more, or they don't, or they find a different field that they liked. But I just personally didn't figure it out until probably end of my third year. How competitive is emergency medicine? Currently, and again, it's cyclical. There are times where certain things are more, but I would say over the last 10, 15 years, I would say emergency medicine is probably one of the most competitive fields. I would say, and partly I would say it's because the competitive of a field depends on a couple factors. One is how many people are trying to get into it, of course, how many programs there are. But over the last 10, 15 years, and even right now, it is definitely one of the most competitive fields. So certainly if you are interested in emergency medicine from day one, you might want to try to explore and get some exposure. Most med schools will have a emergency medicine interest club, so you can see if that's what you want, because you want to start kind of, again, just getting some exposure to see if that's what you really want. But typically you want to make sure that, obviously your test scores are high, your rotation scores are high. And one of the ways that they measure how competitive a specialty is that in residency, there's so many spots in the country, and the fields are very competitive. There are way more people trying to get into those spots than are available. And there's some fields that aren't as competitive. And so what ends up happening is if there's 100 spots for a field, but they can only fill 60, then that tells you that it may not be as attractive than a field that they fill 99.9% every single year, And it's cyclical. There was a time where anesthesiology was not very competitive, and then there was a time where all of a sudden everybody wanted to go to anesthesiology, and then became very competitive. And so it's cyclical. But I would say currently emergency medicine is very competitive. I would presume it's going to continue to be competitive, and the reason being is that if you look across the country, there's a statistic that I think I want to say 40% of all emergency departments are still not staffed by emergency medicine trained physicians. Now, all the major cities, it's very unlikely that you walk into an ER and you're seen by someone other than an emergency medicine trained physician. But there are areas in the country, more rural areas, where it's tough to recruit physicians. Where you walk into the emergency department, it might be staffed by the local dermatologist or the local primary care doctor, and that's how emergency medicine used to be. 30 years ago, when it wasn't a formal field, you got whoever you got. And as you can imagine, it would be a little, scary if you had a trauma, but then you're being cared for by a radiologist. Again, I'm just, making up, exaggerating some examples. So, and so, so I think there's still a lot of demand for emergency medicine over the next, 10, 20 years. Which is why, and the number of programs are not growing exponentially. So I think it'll still continue to be very competitive. Um, what is your favorite part of emergency medicine? What's your least favorite? I would say my favorite part of emergency medicine is the flexibility to pursue other interests. And also, so that's one aspect, kind of from an overall career perspective. And you'll find a lot of emergency medicine physicians have other interests, and that's just very common. The But within the field of emergency medicine, and again, it's somewhat personality based. I just like the idea that I feel comfortable in almost any situation. It doesn't mean that I'm the best doctor or that I'm the best at everything. It just means that by the very nature of the field, anybody who walks through the door, I need to have been trained, or I should be trained, and I am trained to be able to at least stabilize them or take the manage the initial part of their care. Best case scenario, I can manage entire care, resolve it, solve it, and it feels good. Worst case scenario, I can always still stabilize, identify the systems are going wrong, resuscitate them, get them to a point where I might then identify, oh, at this point, you need to go to a heart surgeon, or at this point, you need to go see so and so. But it's that feeling of like, and I give a lecture every year on, caring for a patient on a plane, like what happens when an emergency happens on an airplane. It's that feeling that, if you're called upon and people see you have an MD after your name, it's nice to be able to feel like, okay, well, I've got an MD after my name. I should be able to help whoever needs help, and not say, oh, sorry, not me. So that's kind of at least at a personal level, how what I like about it. So yeah, someone interested in pursuing combined MD MBA, have you found the MBA portion? Yeah, so that's a common. So I actually started the administration fellowship at Stanford. So if you are a physician finishing emergency medicine, I have a 2-year fellowship that you can go into, focused just on being kind of a healthcare executive. And so the common question is, what do you do with the MBA? Is that helpful? So I would say the MBA can be helpful. It opens doors. It shows people you're committed to learning more about administration. You can absolutely be successful without the MBA. Absolutely, there are a lot of people that are CEOs and or run Fortune 500 companies without MBAs. As a physician, it can be helpful because when you're a physician, everyone's going to think of you as a physician. They're going to think of you as caring for patients first. It sometimes can be hard to be credible in a board meeting, because again, they're going to kind of pigeonhole you into being a doctor. And so sometimes having that MBA can help. I mentioned I got the MBA for a slightly different reason, not because I thought I was going to do healthcare administration, but I wanted to go into venture capital and investment banking and entrepreneurship. And so, so it was a great way to allow kind of access to those communities that otherwise you can't as an MD. So kind of what I'm doing now, I think kind of combines a little bit of all that in the academic world. But otherwise, I would say the MBA is helpful. It's not mandatory, but it's certainly is nice. And we are seeing so many more residents now coming to our program that have done the MD, MBA, or we are seeing a lot of our graduates go on to do MBAs. I would say if you're going to do the MBA, I would do it early. I certainly would recommend, again, you can do it anytime, but it's nice to get it done earlier than later because you're going to find if you start residency or when you finish residency and you're working full time, it's really tough. And I personally wanted to do a kind of a full-time 2-year MBA program because I wanted the full value of it. I didn't necessarily want to do an online program, and because I wanted that ability to be in person, do didactics, work on projects. Not that you can't online, but there's just it's a different component, it's a different feel, and it depends on what you're looking for too. But I think doing it early, I would say that it definitely helps. Um, all right, I think I'm explaining kind of at least my interest in the MBA. Yeah, next question. Do you participate in specific experiences before medical school that led you to pursue medicine, not another career? That's a really interesting question because when I started college, I was very much thinking pre-med because I just happened to like sciences. I didn't in particular have an exposure. It's not that I, like my parents were physicians, so I did have physicians in my extended family. But I just knew I liked science. I knew I liked kind of that intellectual piece of biology, chemistry, and yeah, so but I did, so my opportunity to pursue another career was so I did get into med school, and then my girlfriend at the time was doing the traditional investment banking management consulting route, and so I actually saw her kind of go through the typical recruiting cycle where you're looking at these corporate jobs, and so I actually applied for a job just for the fun of it, and I got a job in management consulting, and so when I thought about it, I figured this gave me a chance to explore another career to make sure I really wanted medicine. And UCLA Medical School let me defer. So once I got accepted, they let me defer 1 year to hold that spot. So I did management consulting, and I really loved it because I had no exposure to economics, I had no exposure to accounting, nothing like that. But I did it, and I really enjoyed it. And they let me defer a second year. So I spent 2 years in management consulting before I started medical school. And I truly, truly felt that was like an incredible experience. And still, I have more impact on my career than I think the MBA. So for me, that was my opportunity to see a different career. But having done that and working with investment bankers and with entrepreneurs, I still felt like I really wanted to just do clinical care. And so that's why I did obviously complete my medical school. But I felt like if I can get the best of both worlds, if I can still take care of patients, but in a way that was in a career that was flexible, that allows to support my interest in entrepreneurship and some of the other things I liked about consulting and business world, then that to me kind of was like a light bulb that went off to say, hey, if I can combine all that, then that would be very fulfilling for me. And so I think I appreciate medicine more because I had a chance to explore something else, as opposed to always wondering, gosh, am I doing medicine because that's all I ever thought about, or that's all I ever knew, or whatever. So I think I would definitely encourage you to make sure you keep an open mind. And there's ways that you can be exposed to other things. It's very good because medicine is such a long road. I mean, it's 4 years, then 4 years, then 3 years, and this. You hate to go down, 8 years into it, and then realize you want to do something else. And I do have friends from medical school, from residency, who've left. We had someone in our Stanford residency program that left after the first year to do management consulting, actually, or to join a startup, or to do something else. Yeah, so excellent question. How do you prepare yourself mentally for the intensity and stressful? There's a lot of focus on wellness in emergency medicine. So I would say in 2021, when you go into this field, there's a lot more support for it. And I would say really the intensity the stress comes from when you don't know what you're doing, right? Like anything, right? If you feel like you're walking into a class or walking into a situation where you don't know what you're doing, then it's extremely anxiety provoking. And so I would say most people, when they finish, the anxiety isn't from the clinical part because you will be well trained. Every program in the United States, every medical school will train you very well. I think the intensity and stressful really comes from all the other stuff that surrounds it. How do you balance your career with your friends and family and home life and all those things? Those are oftentimes the more stressor than caring for someone with a heart attack, for example. What inspired you to? Oh, sorry. what inspired you to pursue emergency medicine compared to other fields? Hopefully I think I explained. Yeah, I talked about that. I will keep going. Um,
Dr. Shen, I actually
yeah,
have a question.
yeah.
Uh, yeah, so I am actually planning to go for the MD MBA, and I'm sorry if you touched upon this. My audio is going in and out. Um, but I am unsure like how to be like a competitive applicant for like the program itself. Because recently I've taken like a small finance internship to like set myself apart from others. But like, is there like a specific route?
Yeah. So for the MBA part, what the MBA programs are really looking for is, um, um, first of all, you want to have a very compelling story for why you want that MBA. All right, and usually, if you got to a point where you're thinking about it, usually you can at least describe right what your motivation is, and it has to fit right. Whether it's to say that, gosh, I want to be a healthcare leader in the future, and this will allow me to learn the skills to interact with other healthcare leaders, and I can combine that with my clinical perspective. But the other thing that's really important is experience. There are some business schools where they won't take anyone straight out of undergrad. You need minimum 2, 3, 4, 5 years of work experience in order to even be competitive to apply. And there's some that will just treat the MD. If you're applying to medical school, they will assume that by the time you do the business school part, you will have had a couple years, 2, 3 years of the medical school part that counts as experience. And so, if there's something you can describe in your undergraduate that you've done that demonstrates an interest or some experience with managing a project or leading some effort. It doesn't have to be massive. Not everybody needs to be able to say that you started a company in undergrad. You don't need to do that. But even something as, hey, there was a problem I was dealing with in undergrad. I was part of some organization or club or something where we looked to address that problem, and I can talk about how I took it from point A to point B, or I led high school students in this. They just want some experience, some concrete evidence that you are engaged in becoming a future leader. Because the whole point of the MBA is that in their mind, they're thinking everybody we graduate from an MBA will eventually be some sort of leader, some sort of executive, some sort of position of authority. And so you just want to be able to demonstrate that track, just like in medical school. Applying to medical school, you're trying to demonstrate that you want to do something that shows that you want to obviously care for people. You want to make people better. You want to advance the science of medicine. And so depending on the purpose, to be competitive, that's probably the best advice I would give.
Okay, thank you.
Um, all right, what was your undergraduate major? Again, I was a very standard, I think, pretty cliched pre-med. I was a biology major. And as I mentioned, that's when I was applying for that management consulting job. I felt a little bit like a fish out of water because I never took a single economics or anything that would really tie to that. But in some ways, so I would say that it is not an advantage to be a biology major anymore. I think in the past, being a biology, chemistry, science major shows that you're very committed to medicine. Nowadays, what I find is that the people are very competitive. Obviously you have to take all your pre-med courses, but if you're a different major, in some ways it makes you stand out. If you're an English major, a art history major, something else that shows a little diversity, because medical school want people with different perspectives. You don't want every single person that all they cared about was the, I don't know, the Krebs cycle, and that's all they studied, and because it makes you in some ways less interesting, and so when you go to that medical school interview, they're thinking like, oh gosh, when you go work out and you're taking care of patients, not all patients are going to look like you, talk like you, think like you, and so it's good to have that diversity. And again, when I was going through med school, I felt like it kind of hurt my chances, which is why I applied to medical school and made sure I got that spot and deferred before doing management consulting, because I felt like if I did management consulting and tried to apply to medical school back then, it would have been viewed as you're not very serious about it. So why don't we take someone else who's more serious about medicine? Whereas now, I would say almost every single medical student, at least the ones that we take at Stanford, they all have like done something else. It's okay to take a gap year. It's okay to, we have people who are in their mid 20s because they took 5 years off to do something else. I'm not saying you have to. I'm just saying that I would not view it as a detriment that somehow you're not as serious. And your major, so therefore your major can be anything.
Dr. Shen, if you
Yeah.
allow me to kind of take up on that point, how do you, so it's been made feel by a lot of people that kind of like what you're saying, if you have this 5 year gap and you are in some sort of business development role, that you may not be taken serious when you apply to med school. So how do you frame it in a way that shows med school, like for example, if you're not applying to an MD MBA program, how do you use your business development skills and your 3-4 years experience in quality assurance or a type of sales role in the science field to kind of demonstrate that you're a competitive candidate?
Yeah, I would say now is of all the times is the best time to be able to put those pieces together. And I say that because healthcare is so complicated in 2021. With the and it's like the hot topic, right, on a political landscape, on the national landscape, that the most classic, compelling story is to say that you as a person who wants to care for patients need the ability or need the experience and the expertise to not only impact that patient in front of you, you need to be able to have an impact at a much larger level. And so that's kind of how I shared my view. Because when I was applying for residency, same thing. I would get asked, "Wait, you went to med school, you went to business school, you did this. Why are you interested in even practicing medicine?" And of
Mhm.
course, my story, which is very true, is that I want to care for patients, but I also know how complex the healthcare industry is. And I want to have an impact on the healthcare system beyond one patient at a time. And in order to do that, I need to understand the business aspect. And to do that, that's why I needed to get more formal training. I needed to be out in the real workforce so that I can pull all those experiences together so that when I do care for patients, I not only understand the clinical care of someone with a heart attack, but I understand a system level how that patient fits in to our insurance industry, how they fit into a hospital trying to be a business, how they fit into the dynamics that come with economics of healthcare being so expensive, and so that I can then be a leader and a physician advocate in the future. And so I feel like that's a very compelling story, and that I would say that is a common reason why a lot of people, as physicians, want to get that background, right? Because they want to walk into a boardroom and be taken seriously, not just as a doctor, but as a peer to the CEO, COO, the directors, and so I feel like when I go to those meetings, and I can advocate for patient care. I can advocate for whatever I want to advocate for. That I can, in a sense, speak their language too. I can appreciate their perspective because it's tough, right? If you're not to say everything's negotiation, but if you're trying to create change for the positive, not everybody's going to be on board. You have to understand their perspective, and that's a classic dilemma in medicine that physicians and administrators often don't trust each other. Physicians think administrators all they care about is the dollars. The administrators always think the doctors all they care about is just the not that it's just, but they don't appreciate the economics beyond just caring for the patient. So that's always a classic dilemma. And so if you could be that hybrid person that can straddle both sides, you're going to be really, really effective. So hope that answers that question.
Thank you very much. It does. It does allow to put it into perspective, especially with precision medicine coming on board and how companies, it's not all driven by the dollar, but it's important to keep that in mind. And precision medicine is very expensive. So there is, from a physician standpoint, you have to find a way to bring down the cost. So it is the social cultural gap is not widened. So thank you for your words. I've
That's
truly.
right. And that precision medicine, it's interesting you mentioned that because, at Stanford, in our department, we have a whole strategic plan right now all around precision medicine because that is, probably the future.
Mhm.
Can the interest be for business MDMA be frowned upon? I think I kind of answered that. I think it's if you can tell a very compelling story for why you want to combine the MD and MBA, which there's many reasons, I think you'll be fine. What's been your most jarring experience in the ER? I would say, I would say the most jarring is usually when patients when they die. When someone comes in extremis, especially when the family's there, and especially when it involves kids. I've just been involved. I've cared for a lot of patients who are kids, teenagers, adults. Doesn't matter what age, where they come in and based on their condition, or especially when it's traumatic, car accidents, stabbings, shots, stuff like that, and then having to tell the family that just literally a matter of a few hours they were just talking to them, and now a few hours later you have to be the one to tell them that they didn't survive. I would say that's probably still the most jarring. And obviously there's a lot of support in the emergency department to help you with that, but I would say that's probably the most, especially once you have your own kids, then it becomes even more jarring. But it doesn't matter. I mean, or the ones that happen on Christmas Day, because you just feel like, gosh, that family forever is going to associate Christmas or the holiday or whatever day with that death. So what would you recommend focus on doing undergrad to get to medical school? I would say there's nothing in specific to focus on. I think any major is fine. I would say just be very good at what you do. So if you want, like I said, if you are art history major, that's great. Just be a great art history major, and really be able to talk about why you chose it. But again, there is really in my mind, no advantage for one field over another versus 10, 15 years ago, where, it probably shows commitment if you were a biology major. But now if anything, it's more diversity. Do you recommend a fellowship? Only if it meets your career needs. Again, I have we have graduates that go on to do fellowships a lot because they want to stay in academic medicine. And nowadays, if you want to be a emergency medicine physician that does toxicology, you need to get toxicology fellowship. Again, 10, 15 years ago, you didn't. And so it just depends on what you want in your career. But we are finding with medicine, it requires more and more subspecialty training now. Emergency medicine, again, there are about, there's probably about 15 different fellowships out there, depending on what you want to do. Benefits of an MBA over science-related masters, it also, again, just depends. We have a lot of people who get the Masters of Public Health, MPH, and that tends to be more research-oriented, whereas the MBA tends to be, people who may not be thinking about doing pure research. It doesn't mean that you can't cross over. It just, it just tends to be what you might be interested in. How much flexibility is there in your schedule? When you're just doing community hospital medicine, there's a fair amount of flexibility because you work your 12, 13, 14 shifts a month, and that's it. The rest of the time it's yours. So the only flexibility sometimes in terms of trying to get your schedule, what days you work, what days you don't, that's just working with your other physician colleagues. In academic medicine and in more administrative, I would say there's a little bit less flexibility because it tends to start to look more like a 9-to-5 job because of administrative stuff. Do you find your education to be more difficult? You have to cover a wide range. Yes and no. I would say every field, there's just a lot of content. It's just that in emergency medicine, it's just spread out over such a wide topic. Whereas in other fields, you have to have so much depth, but the volume is still going to be about the same. Okay, the methodological approach to emergency medicine fails. In this case, what is done? I'm not sure if the question is more that if the treatment fails or if you don't know what to do next. But I would say, the framework of emergency medicine is such that there is always something you can do. And also don't forget that in a hospital, you can call on your colleagues as consultants, right? So I don't necessarily need to know the minutia of every single cardiovascular disease to the nth degree. But if it gets to that point, then I can call on my cardiology colleague, and that's what a consult is. I will consult my cardiology colleague and say, hey, I've got this patient looking like this, I've tried that. What do you think? Now, the irony is the sicker the patient is, the easier they are to take care of. Because when someone's dying, it is much easier to care for someone like that in terms of stabilizing them than if they're well. And a good example is I'll see someone, they'll say, you know what, I have this weird twinge in my chest. I've had it for 3 years. I don't know what's going on. Why do I feel like that? And sometimes I get a little nauseous. Sometimes I feel this, I feel that. if they've had it for 3 years, clearly it's not necessarily anything life threatening. You can run a million tests and you may not necessarily find out what that is, even though you know legitimately they shouldn't feel like that. And that could be a diagnostic dilemma. And you may never know what it is. But if someone's heart is about to stop, their blood pressure is low, their heart rate is elevated, they're not breathing right. At that point, the body is reduced to certain organ systems: your lung, your brain, your heart. And at that point, you know all the tools you have to make those organ systems function better. And so that's the irony, is that you in some ways feel much more comfortable when someone's really sick than when they're not sick. Um,
Hey guys, since our session is coming to a close really soon, if anyone has any like last minute like important questions, please unmute.
Yeah.
Go
Hello.
ahead.
Yeah, I had a question about like shadowing hours and volunteering hours. I've heard lots of things about this. Like some people recommend 200, some people say 500. Do you have like a number that you would recommend us doing?
I don't, but I know what you mean, because there are some
Mhm.
schools that will ask and maybe even set a minimum. I don't. I think a lot of it might be just tailored to what schools you're applying to and to meet
Mhm.
that checkbox. Obviously, from a personal reason, I would say do whatever you need to do to feel comfortable that it helps you solidify your decision making. So if you were kind of
Mhm.
on the fence about medical school, you're on the fence about a certain field, then maybe you need 200, 300, 400 hours for you to feel comfortable. But if you already know exactly you want to go to medical school, you know exactly what you want to do, and you're
Mhm.
confident no matter whether you do 200 or 500, you're still going to apply to med school, then it's just more of just making sure you check off the box and do the requirement, and pick something that you enjoy, so that it's
Yeah.
not so it's an enjoyable 200 or 300 hours.
All right, thank you.
If anyone else have any important questions, please unmute right now.
So how does the
Otherwise,
shift
oh,
schedule?
sorry, go
Oh,
ahead.
yeah. So how does the holiday shift scheduling work for you usually?
Oh yeah, so it's pretty simple. You kind of just share it among all your groups. So if you have if you work in a hospital where there's 20 emergency physician doctors, essentially you just try to be democratic and equitable. You just kind of share it equally. And then as you get older, you'll find that the older doctors tend not to want to do overnights, because it gets just hard on the body. And so they will say, oftentimes to the younger docs, to say, "Hey, I'll work your Christmas Eve, or I'll work your whatever, New Year's Eve if you work my overnight," and so yeah.
Thank you.
If you guys can look in the chat right now, I have put our link tree where you could find out more information about our events and our organization. And also I put our virtual shadowing quiz for this session in the chat as well. Thank you, Dr. Shen, for coming on and helping out the organization and giving us more information about your field.
Great. Good luck, everyone.
Thank you.
Thank you so much.
Thank you, Dr. Shen.
Thank you so much, Dr. Shen.
Thank you.
You're welcome.
Thank you, Dr. Shen. It was an honor to have you.
My pleasure.